So the idea of cost of care, it should be simple. It's incredibly complex. And here's why it's complex. So you walk into a store and you want to buy something. And you have an idea of what you want to do. It can be anything. It could be a pair of shoes, it could be a car, it could be an iPhone. You go in, it's there. You've done your shopping and you say, I'm going to buy it, and it costs X dollars. You get it, and it does what you want it to do. You buy health care with the idea that my health care is going to cover me no matter what happens to me. You don't think about, if I get cancer and I need an immuno-oncology drug in the future, I got to make sure this health care is good for that. Nobody thinks that way, not even doctors. So from the payer perspective, the payer looks at a 3-year time window, tops, because people move from insurance to insurance. So if they're going to expend X dollars on you, they want to make sure your premium covers that in some way, or your risk pool covers that in some way within that 3-year period. With CMS, it's 5 years, but nowhere in there is it 10 or 20 years. So now, flipping that around, if I'm 40 years old and I don't have cancer, I'm otherwise healthy, I have at least, actuarially, another 35 to 40 years of life, and probably longer than that now. So I'm not thinking 3 to 5 years. So if I then, along the way, make a left turn, if you will, and develop metastatic melanoma, and there's a drug now called ipilimumab that has a 20% 10-year survival curve, whereas before there was a 0% 10-year survival curve, more or less. I want that ipilimumab drug, don't I? If that's the best there is, and it's going to get better with the other drugs. So I'm not thinking 3 years, 5 years. I'm thinking I want that 40 years back. So that's where the problem is. It's not that the insurance companies don't want to pay for drugs. In fact, I've not met a single insurance company executive who wouldn't want their member to have that drug, or CMS. The problem is they live within a budget and an actuarial budget. So how do we do this? So what we have to show is that in that 3-year time frame or the 5-year time frame, if you don't give the drug, this is all the money you're going to spend on all this other stuff. Whereas if you do give the drug, yes, the cost of the drug is expensive, but it's being offset by all these other things that aren't going to happen. That's total cost of care comparative analysis. So I have made an argument recently, and it's gotten national attention, that while it's important to focus on the cost of the drugs, they can't cost so much that they make everything else unaffordable. We can't just focus on the cost of drugs solely. That's a mistake. It'd be like buying a car and saying, I can't afford this car because the tires cost twice as much as they used to, when in fact the total cost of the car is $1,000 less. What do you care what the tires cost, right? So we have to start thinking that way. And one of the problems is for the public is they don't have any idea about how this works. As a practicing physician, it took me a decade to figure this stuff out, about how it's looked at. Why would an insurance company say no as an oncologist if I say my patient needs this? I have a board certification. I trained at a famous place. Why would they say no to me? I mean, I couldn't figure it out in the beginning, but now I understand. So I think it's so important for the country and for the public to understand that, yes, this drug may be expensive, this technology may be expensive, but what does it do to the natural history of the disease, and what does it do to the total cost of care? Those are the two fundamental questions we must ask. Now, if you have an expensive drug that doesn't improve the natural history of the disease, well, no, of course no one wants it. If you have an expensive drug that changes the natural history of the disease and offsets a bunch of other costs, why wouldn't everybody want it? You know, once you make the decision to use an immuno-oncology drug, we have to assist the patient in getting appropriate coverage because these drugs are very expensive. So for people who have no insurance, we go through the channels of charity care. For people who have limited insurance, there are programs that the pharmaceutical industry offers to help those patients, patient assistance programs of a variety of types. We have to have good relationships with our payers. And we're doing this prospectively with regional cancer care associates, where we're telling the payers what we're going to do, when we're going to do it, and trying to limit pre-certifications and showing the payers the data of when these drugs are approved. We are just beginning to scratch the surface of the impact these drugs are going to have on payer budgets. And I think you'll see the payers over the next several months to the next year really start to pay attention to this. So I encourage all practicing physicians to establish that prospective relationship with their payers to make them understand when we're going to use these drugs, how we're going to use these drugs, and assure the payers we're not going to use these drugs when they're inappropriate to use.